Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liabilities to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content, which is provided as is and without warranties. For all athletic trainers who are intending to get live CEUs from the BOC, you'll receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. All right, so Dianna Lunsford is a former professor and program director for the Occupational Therapy Doctorate program at Gannon University in Ruskin, Florida. She has been an occupational therapist for over 30 years and a certified hand therapist for 25 years. Dianna earned her post-professional Doctor of Occupational Therapy in 2012 from Rocky Mountain University of Health Professions. She has worked in a variety of settings and is passionate about advancing the profession through scholarship and service. Dianna is a published author and presenter. Dianna is the senior editor for the ASHT Times and a member of the ASHT International Committee since 2015 and an occasional editor for several peer-reviewed journals. And Moscony is an assistant professor in the Occupational Therapy Doctorate program at Gannon University in Ruskin, Florida. She has been an occupational therapist for over 40 years and a certified hand therapist for 30 years. Anne earned her post-professional Doctor of Occupational Therapy in 2019 from the University of St. Augustine for Health Sciences. She has worked in a variety of settings and locations. She has presented locally and nationally on a variety of topics, including management of chronic pain and management of common hand and upper extremity conditions. She is a published expert on the topic of evaluation and management of peripheral nerve injuries. And they're going to be presenting today on game-changing finger injuries. And ladies, I'll have you take it away.
Thank you so much, Michelle.
Yes, thank you all for being here today. My name is Dianna, and
my name is Anne.
And we're going to be talking to you today about extensor tendon injuries and deformities that you may be seeing in sports. There are no financial or otherwise disclosures to share with you today, and we are not involving any unlabeled use of a product or anything of the kind.
So participants will understand the extensor tendon anatomy of the digits of the hand and identify and differentiate digit extensor tendon pathology associated with mallet finger injury, boutonniere injury, and swan neck injuries, and also identify appropriate therapeutic interventions for conservative management of mallet finger injury, boutonniere injury, and swan neck injuries, including the selection of the appropriate orthosis or splint design upon completion of this seminar. So I'm going to begin with a little bit of statistics. Extensor tendon injuries are a common subset of hand tendon injuries, and they account for a substantial share of orthopedic soft tissue hand trauma, especially those seen in a hand therapy practice. In a 2014 10-year population study, extensor tendon injuries were seen significantly more frequently than flexor tendon injuries. The highest incidence of these tendon injuries occurred between the ages of 20 to 29 years of age, and males had a higher incidence than females. In children, those younger than 15 years with extensor tendon lacerations, while 98% of the digits were rated as having a good or excellent outcome at the 2-year follow-up period, 22% of these fingers still showed extensor tendon lag or a loss of flexion at follow-up. In a 2015 study, 60% of all hand injuries that occurred in ball sports involved the fingers, and the most common injury was closed rupture of the distal interphalangeal joint extensor tendon, or a mallet finger injury. Injuries to the finger, those that are more distal in particular, were reported to have had a significantly poorer result than more proximal hand injuries. A 1990 study reported that 60% of all finger extensor tendon injuries sustained an associated injury, such as a fracture or dislocation, or joint capsule or flexor tendon damage. And additionally, this study reported that injuries of the PIP joint and or of the MCP joint of the fingers were reported to have high functional relevance, as these injuries frequently required more complex or consisted of more complex lesions requiring more demanding diagnostics and therapy. So the implications for athletic trainers in particular are that given the incidence in athletes, be alert, especially in sports with high finger trauma risks. So sports that involve ball sports or contact sports. Mechanisms matter. So if this injury occurs because of sharp trauma, laceration, falling onto the finger, jamming injuries, or mallet type mechanisms, you need to be considering if there might be some associated injuries as well as an injury to the extensor tendon. Errors in diagnosis or insufficient treatment can lead to misalignment and long-term functional implications for the hand. So quick recognition and appropriate management can facilitate more timely return to play and a better outcome for our clients or for our athletes. So let's take a second and review the anatomy. I'm going to, hopefully you can see my little cursor here. I'm going to start by saying that when we look at tendon injuries, we divide the hand and forearm into zones, and we identify those zones according to common injury patterns and management principles. So on the extensor surface, we have 8 zones moving from distal of the tip of the finger to proximal. So zone 1 here is over the DIP joint. The typical injury here would be a mallet finger injury or rupture or avulsion of the terminal extensor tendon. Zone 2 consists of the middle phalange, and lacerations or crush injuries are typical at this level. In zone 3, we see the PIP joint, and common injuries here would be central slip or boutonniere injuries. Central slip and boutonniere are used interchangeably. In zone 4, the proximal phalange, we'll typically see lacerations or crush injuries that affect the extensor mechanism. Zone 5 is over the metacarpal phalangeal joint, and at this joint, we commonly see what's called fight-bite or human bite injuries or lacerations across the knuckle. And we go down to zone 6, which is the back of the hand, zone 7, which is at the wrist or the carpus, and zone 8 down into the forearm. For today's talk, we're going to focus on zones 1 to 3 and injuries that occur typically there. So we're going to start by reviewing some of the anatomy. If we look here, this is the proximal phalange. Here we have the middle phalange, and here the distal phalange. Here is our PIP joint, and right here is going to be our DIP joint. So if we look underneath here, if this would be our metacarpal and our proximal phalange and our middle phalange. So this is your PIP joint right here. Notice this structure right underneath. This is a ligament, the volar plate. It's designed to prevent hyperextension at that PIP joint. Also notice here we have some important ligaments called collateral ligaments. They prevent the middle portion of the finger, the PIP, there's also ones here at the DIP, from moving voluntarily in a lateral direction. Instead, this ligamentous system allows us to move in flexion and extension only at both the PIP and the DIP joints. Now let's move up to this top picture here, and let's talk about a primary extrinsic extensor tendon, that an extensor muscle that will be involved in finger straightening or finger extension. And that would be your extensor digitorum. Some books will call it the extensor digitorum communis muscle. I like to think of this as a communistic or socialistic muscle that allows for extension at all digits. Digits 2 are the index, 3 are the long finger, 4 are the ring finger, and 5th on the little finger. Here is, so the muscle belly itself is down on the proximal forearm on the dorsal aspect. When it contracts, it pulls on these ropes or tendons right here. And here's the first portion where it crosses at the MCP joint, and this is where it'll extend that MCP joint. So if you right now take a second, I'm not sure that you can see me, but I'm going to assume that you can't. So I want you to make a claw hand and pull those MCP joints into full extension, and you should be able to see the extensor digitorum kind of pop up in the back of your hand. Now, if we go a little bit further, this tendon doesn't just do extension at the MCP joint. It sends fibers distally. On either side, it sends some of its fibers to the lateral aspect of each of the fingers, right here and right over here. And then it continues on distally in the central portion to insert into the middle phalange and becomes the central slip. So this central slip is capable of extending the PIP joint if we prevent MCP joint hyperextension. Now, let's look at the side, this little picture here. This is a very simplistic view of this extensor system. Here we see the continuation of the extensor digitorum going into the central slip, inserting into that middle phalange, so it can extend that PIP joint. And then we see this structure here called the lateral bands. So the lateral bands are composed of some of the fibers from the extensor digitorum, as well as fibers from your lumbricals and your interossei, both groups of small intrinsic muscles that originate in the hand. These fibers will extend all the way up and form a lateral portion of the extensor mechanism, and they will go on to insert over top of that distal phalange to extend and become part of the terminal extensor tendon that extends your DIP joint. This makes this whole system look pretty simple. It's actually a little bit more complicated than that. So let's take a look at the next picture and orient ourselves to this. So here we have the extensor digitorum. It's inserting right over the metacarpal phalangeal joint here. This tendon is held stable or on top of that dorsal surface by these sagittal bands. Then we see the extension coming over to the central slip on the top here, and we see that it's contributing some of the fibers on the side here, along with fibers that are coming up from the lumbricals and fibers coming up from the interossei muscle. This gives us a very nice picture on the bottom here, where you will see the fibers from the interossei muscles are in blue, and fibers from the lumbrical muscles are coming up in this kind of light greenish color, and they're joining into this whole mechanism, which they call the extensor hood. So you want to think of the extensor hood as really an aponeurosis, or a big, broad, triangle type material that covers the dorsal aspect and both lateral aspects of your finger. All aspects have to work in order to allow us the very intricate kinds of things that we do with our hands that allow us to extend our MCP but not our IP joints, or allow us to extend our IPs but not our MP joints, etc. So that complicated interplay is necessary for the smooth coordinated movement that we have and that we expect.
Great. Well, so now that we are all on the same page with the anatomy, I want to talk about the mallet finger. What you see here in this image enclosed in the oval is a typical view of what a mallet finger looks like. So mallet finger is classified, as Anne mentioned, we're broken up into zones. So between zone 1 and zone 2, with or without an avulsion. But in a zone 1, that mallet finger accounts for the majority of all finger fractures with a crush mechanism. This can happen during sports, for what many of you, I would imagine, are dealing with, but it can also happen for during household or work activities as well. It's most common in young males until about the 5th decade, so about 50 years old, and then the incidence is about equivalent for men and women. The middle finger, the ring finger, and the small finger of the dominant side are most commonly involved with mallet finger. And zone 2 is typically the result of a laceration. And I'm going to get into the classifications here in a moment. But if we leave the mallet finger alone, it doesn't get better. Unfortunately, over time, it can get worse, causing osteoarthritis to develop at the DIP joint, or even swan neck deformity, which will include more of the proximal digit, and that becomes problematic for function. So zone 1 and zone 2. All right, so according to the Doyle classification system, there are 4 types of mallet. So type 1 is a closed mallet injury. This can happen with or without a piece of bone coming with it. So there's no tissue, soft tissue, external tissue loss, but there is tendon disruption, most common injury. Type 2 is a laceration at or proximal to the DIP joint. And again, because it's a mallet, there is loss of continuity of the tendon. When we get into zone 3, or type 3 rather, we're looking at a loss of skin, subcutaneous cover, and a loss of tendon substance. So we think of mechanism of injury. Type 1 can be a direct hit with another player, a direct hit with extended fingers on the ground, or with equipment, game equipment. Zone 2, or type 2, I apologize for mixing these up. Type 2, more of the same type of injury. Type 3, I think about a hand on the ground and making contact with a piece of equipment like some sort of lacrosse or hockey stick, or shoe cleats, something that's causing that deep abrasion and kind of taking away with it the cover of the skin. And then your 4th type is in kiddos with a plate fracture across the transepiphyseal plate. So what do we do with the mallet finger? Well, if we're looking at an acute injury, we want to splint this. Now, we're hand therapists, so we would normally call this orthoses. But for today, I'm going to refer to everything on the finger as a splint. We can make a volar, or dorsal, or a circumferential splint, as you see on the images on the left. And for an acute injury, we would be looking at 6 weeks of continuous wear. What I want to emphasize here is this is continuous wear. What happens with the mallet finger is there's this disruption of the terminal end of the tendon, again, with or without bony or tissue injury. But what the body doesn't like is it doesn't like empty spaces. So if we lift that finger into complete extension or slight hyperextension of about 15 degrees, and we keep it there, that will fill in with scar, and it will essentially heal that mallet finger. But that's 6 weeks of continuous wear. If your athlete, I'll say my patient, your athlete, decides, oh, at 3 weeks, they're gonna check and see if the finger will bend and straighten, 3 weeks isn't enough time to make that solid. And what they will do is tear up everything that has laid itself down in there, and they have to begin at week 1 again to start healing. So it's really important that we educate our people, our athletes, and they have an understanding that they can't do that. So that means for showers, maybe we have a dry splint that they put on outside of the shower, and they wear that splint during the shower so that they are maintaining that position. When they dry the finger, that they hold it up physically and maybe have assistance to help dry the finger. So we want to make sure that those things are accounted for and that we have those conversations so that there isn't any question about what they're doing when they're not with you. So that's a 6 week for an acute injury. A chronic injury, we can fix a chronic injury too, but the further out we get, and what the literature is defining as chronic, is after 4 weeks. So that doesn't seem like a very long time, but after that time, our outcome decreases. It's not as positive of an outcome. So although a chronic injury, we can still splint that injury years after an injury and have some results, it's not going to have great results. So keep that in mind. So for a chronic injury, we're looking at a continuous wear of that orthosis, morning through the night, showers, all of it, for 8 weeks after the initial injury. Once the splint is removed, night use should continue. And this is where you get to use your clinical judgment, because you know what your athlete is doing. For us, if this were my patient, I would be telling them, you know, perhaps we want to use your splint during the day when you're cleaning your house, or if you're going to be in crowds and you might get bumped. So there may be times to put that splint on during the day for protective purposes, and continue to utilize it. So talk to your athlete, find out what their preferences are, find out what they're doing during the day, what their lifestyle looks like, and then help guide them in a wearing schedule. Home programming is really important. Range of motion, tendon glides are always a component of the home program. We avoid passive range of motion and pushing on that tip because it doesn't need it. The flexors are much stronger than the extensors. So I would rather see a little bit of tightness at the DIP joint and it taking a little bit longer to get a full flexion out of that finger than have a lag that we have to re-splint for more time. So a little bit of DIP tightness is okay. It will get there, and we want this to happen over the course of weeks. Lots of options for splinting. I've got plenty here, and there's plenty more out on the internet. So we'll start on the left with the oval A. This is actually one of my favorites. It's hard to see because it's flesh colored, which is why a lot of people like it. It is very discreet. And this one is not fitted absolutely the way I would like it fitted. We'd like to see this finger straight as opposed to slightly bent. If it heals slightly bent, it's going to come out of that orthosis, out of that splint slightly bent. So we do want it in extension. We've all seen the stacks type splint. This is what I call one size fits none. They don't typically fit very well, but a little piece of elastic tape underneath a stack type splint can help. It can help it from migrating. One of my favorites is a quick cast. This is a circumferential splint. This is a casting material that comes in 1 inch. It is heated with a hair dryer, turns translucent, shrinks up a little bit. I have my patients grow their fingernail out, and then they can anchor their other hand on their fingernail, bring their finger into hyperextension, and then I apply the quick cast and the splint. It dries in minutes. It can get wet in the shower. It can be manually dried off with a towel and even then blow dried through a little bit. We have to be really, really cautious because this is a continuous wear that we aren't developing maceration, too much moisture underneath the splint. That obviously in time can cause breakdown of the skin and potential wounds. So we want to make sure that we're educating them and cleaning and drying it, but maintaining that extended position. We've all seen the aluminum or the alumifoam mallet finger splint. Again, that works great for especially short term. And then this is something that we would fabricate. It is a dorsal orthosis or a dorsal splint. We would super glue the nail to the back of the orthosis, which helps to maintain that in extension, but allows them sensibility on the volar side. I've seen these actually commercially made as well, where they slip on and you just add the super glue and they're ready to go. So a lot of people like that if they want to still use the tips of the fingers for sensory, whatever tasks they might need that for. So like I said, a whole variety of things for options to help support the mallet finger. For zone 2, which again is just proximal to the DIP joint, if there is active extension, but not full extension, so you've got a partial injury, then immobilization is shorter, 3 to 4 weeks is appropriate. And however, in that zone, if there's more than 50% of the tendon injured, that typically needs to be surgically repaired, and obviously we are not doing that. Considerations, considering volar versus dorsal versus circumferential, again, that is going to be based on a couple of things, on patient preference, on what the goal is from a comfort standpoint or from a sensibility standpoint. A custom orthosis, of course, we are advocates of that because we can make sure it fits that person. And everybody's hand is shaped really differently. So we want to be able to leave the PIP free because least restrictive environment. If we don't need to immobilize a joint, we don't want to immobilize it. But this hand here is a prime example of a really short short middle phalanx. And so in this case, we needed to splint down past the PIP joint because every time we just immobilized across the DIP joint, when they bent the PIP, the orthosis shot off. It just, the lever arm wasn't long enough to maintain it on. Even with tape, it was sliding off. So we went past the PIP joint. And again, that's not typical protocol, wouldn't be traditionally what you do, but in this case, that's what we had to do. So this is where your judgment comes in. Also considering the patient's occupation or sport, you know, do they need to be wearing this and how often? You have a say in that. You will want to make sure that you're educating your patient and being a part of that and what happens during sports and practices. Edema control is another big component of this because in an acute injury, you're going to get a lot of swelling. So if you look at this image on the bottom here, you can see that we've got a perfectly extended finger. It doesn't look like it from the dorsal aspect, but what's happening here is it's really swollen. So this is a fine posture to begin with, but this is something that we're going to have to be on the lookout for because that swelling, especially if you put a circumferential orthosis or Coban on top of that finger, that swelling is going to come down and that orthosis is no longer going to keep that finger extended. It's going to have some wiggle room in there. And again, we want to avoid that. So your eyes on that, if they're seeing a hand therapist, their eyes will need to be on that, something that we need to watch for edema control. We already talked about some of the opportunities for maceration under an orthosis that is on for 6 weeks. The oval 8s work really well because there's a lot of airflow through here. As you can see, some of our other orthoses, like you see in this one too, have perforations, and then some of them don't. Some of them are solid material. So moisture builds up, it's a real thing. We've got to watch out for that. We also have to watch out for any allergic reaction. Many of our materials, the thermoplastic materials now, have a lot less latex in them, so we're less worried about that, but people can be allergic to anything, and we don't want them sticking something in there and scratching their skin because it itches, because they're introducing bacteria and things like that. So always educating. And if we do have a tip injury, particularly a tuft fracture, an injury of the distal phalanx, there could be some real hypersensitivity of the tip, and that's something that we would want to address with some desensitization, massaging, things like that. Patient education, really important. I have found, it's been my experience, the more I educate, the more that they know and understand, the more compliant and adherent to a program that they're going to be. This looks like tape, but quick cast is one of the things that we really like to use for the circumferential taping, and then again, use of some sort of elastic tape underneath the splint for to keep it on and to keep it in place, maintaining position. Now I want to talk to you a little bit about swan neck deformity. I love this image of the swan next to the finger. You can see this is why it's called swan neck deformity, because the DIP joint is down into a mallet looking position. However, if you look more proximately, what you will see, and I'll drop down here to the bottom left picture, is a hyperextension of the PIP joint. So swan neck deformity can develop from a variety of ways, but ultimately it's the loss of the balance of the extensor mechanism not doing its job. So the extensor mechanism at the distal phalanx, it has some slack and is allowing that DIP to drop. And there could be an overpull or a tightening of the mechanism at the proximal area. Things that we typically see, or we often see, is this associated with hypermobility syndromes and syndromes that involve connective tissue issues. Rheumatoid arthritis, Ehlers-Danlos syndrome, CP, hypermobility syndrome. And what you are going to see most likely is related to trauma and injury. So the incidence for a swan neck deformity, and just in general, Anne mentioned already that our extensors are injured much more than the flexors. They're a lot more vulnerable. And the index finger for zone 3, as opposed to zone 1 and 2 that we talked about, middle, ring, and small finger, the index finger for zone 3 is the most commonly injured, with the PIPs being the most commonly injured joint of the hand. Dorsal and lateral dislocations being the most frequent. A volar dislocation is very unusual. Swan neck deformities, again, related to some of these other syndromes. However, let's just talk about this volar plate and these collateral ligaments. So Anne mentioned these earlier. These are often involved in a swan neck deformity related to trauma. And you can see these stabilizing collateral ligaments ruptured and or the volar ligament ruptured. And we'll talk a little bit more about this. So trauma. So you're going to see as trainers a lot of trauma related to this joint. And let me just say that we have a lot of respect for the PIP joint. There's a lot of motion that occurs at that joint. Over 100 degrees of range of motion. If you look at 90 degrees being a box, right? Over 100, I'm quite flexible, but over 100 degrees of motion. And there are very few other joints in the body that have that kind of range of motion. So we have a lot of respect for the PIP joint. It has a lot of flexibility, but it has a lot of complex stabilizing structures surrounding it as well. So a traumatic injury may result from a hyperextension injury. Again, contact sports, contact with other players, contact with equipment, contact with the ground, an impact injury of some sort. But this may lead to tears like we talked about in the collateral ligaments, the side stabilizing ligaments, or the volar plate, which is supposed to protect in that hyperextended position. Buddy taping would be appropriate to the adjacent digit for 3 to 6 weeks if that joint is stable. In contrast to that, if it's a volar plate injury, a dorsal splint would be appropriate for 6 to 8 weeks. And I'm going to show you some images of that here in a minute. But I want to say that the jammed finger, we're going to use that term, it's not a technical term, but the jammed finger is often gets reduced by the player or the trainer there and then on the, you know, I've had patients that have said, well, I just pulled it out myself. And while that can be okay, you got to be really careful about that because there are structures like these torn or partially torn ligaments or volar plate that can get caught intra-articularly. It can get caught within the joint. And then if the joint is reduced, you're going to end up with a lot more pain, limited motion, swelling, and no progress of that joint. And it's going to stay swollen for a lot longer of a time. So reducing the joints on the field, while may sound like a good idea, I would caution against that. And if it does happen, to follow up with your professional because that joint needs to be checked for stability, both laterally and volarly, to make sure that it is in alignment and that there aren't structures caught up within the joint. So again, more splints, more oval 8s, another way to wear the oval 8. And you can see what we're trying to prevent with this is hyperextension. So while this oval 8 covers the surface dorsally, it's allowing full flexion, but not allowing hyperextension. We see a lot of patients that have rheumatoid arthritis, Ehlers-Danlos syndrome, which doesn't ever go away. So some of our clients like to wear these types of splints that look like rings. Silver Ring Splint is one of the name brands that we tend to use or suggest, but there's a lot more out there. The internet is a wonderful thing. These can be made in sterling silver, white gold, yellow gold. You can add jewels. If someone's got to wear it all the time and they want it to look pretty, we give them those options, not covered by insurance, however, options for them to accessorize. You can see in this image here, 2 out of these 3 digits are immobilized, again, discreetly with the oval 8s, bringing them into alignment and preventing this hyperextension of the PIP joints. And should someone need surgical intervention, that typically needs to be pinned. And they pin those in about 20 degrees of flexion for about 2 to 4 weeks, depending. And then we add this type of orthosis post-operatively to prevent that hyperextension again, keeping things in a shortened position volarly. And then we allow active motion, releasing this last strap so that they can bend fully into flexion. Flexion's not a problem to bend in, but blocking them into extension so they can work in extension within the confines of that dorsal hood there. And then we wean from that orthosis at about 6 weeks.
Okay, thank you, Diana. We're going to talk about our last common injury, the boutonniere injury or boutonniere deformity. So a boutonniere deformity is defined as one that occurs when the central slip of the extensor mechanism at that PIP joint is disrupted, producing PIP flexion with compensatory DIP hyperextension, or the classic boutonniere posture. And it's called boutonniere because boutonniere is French for buttonhole, and that's called this because it looks like, if you looked at this, if you were able to open this finger up, it looks like the proximal phalange is the top of a button trying to slip through the lesion or hole that happens when the central slip ruptures. So hence buttonhole deformity. Here is a simple picture of what this might look like. Here is that central slip continuing on with the lateral bands connected to that central slip, which we saw in the more detailed picture, if you will. And here's what happens when that central slip ruptures. Those bands slip down below the axis for PIP extension. So you can see here, those bands are sitting right at the axis. So as long as they contract, they're going to help and assist with PIP and DIP extension. But if they were to slip volarly, when these bands contract and move backwards here, they're going to pull that PIP joint into flexion and pull the DIP joint into hyperextension. Now, the prognosis is really good for treating these joint issues conservatively if they're recognized and treated early. But it's very poor prognosis if left untreated for greater than 2 weeks, which doesn't give us a whole lot of time. So we need to be very conscious about making sure if there are mechanisms that would indicate a potential boutonniere injury that we're testing for this and we are addressing this right away. These central slip or boutonniere injuries are zone 3 injuries, and they have been reported to represent only a small proportion of all hand injuries or all finger injuries. Historically, they account for about 2% of these injuries. So while they're not very common, it's really functionally important to address this because delayed treatment leads to significantly worse outcomes. Okay, so what are some of the typical mechanisms that cause this? A direct blow to the dorsum of a flexed PIP joint would cause this, such as a ball striking a flexed finger, or forced PIP flexion when the finger is actively extended. So again, that jammed finger injury from a ball hitting the finger, such as a volleyball, or from a laceration over the dorsum of the PIP joint that can cause a rupture of that central slip. It's going to present acutely as pain and or swelling over the dorsal PIP joint and an inability to or difficulty with actively fully extending the PIP joint. So you will see an extension lag that will progress over time. You will often see preserved DIP normal extension and flexion early on until those lateral bands really do shift below the axis for PIP extension. So over the next 2 to 3 weeks, these injuries can easily be missed. And as we've said, we want to get those injuries treated right away. What happens if those injuries are mixed is this deformity that can be passively straightened becomes a fixed deformity. The soft tissue starts to adaptively shorten and you can't passively straighten that PIP joint. In that case, that fixed contracture needs to be addressed through splinting before you can even begin a conservative protocol or before you can do surgery on these patients. A diagnosis is made clinically with a positive Elson test. And I have a little YouTube video, which I had difficulty pulling up earlier today. So there's a link here that you might want to watch. It's very well explained. I'm going to go through this with you now, and I'm going to ask you to try to do this maneuver on yourself. So what I want you to do is bend your PIP joint over the edge of a table or over the edge of your chair arm to about 90 degrees. And then using your other hand, resist PIP joint extension. So you're going to try to extend that PIP joint against the resistance of your other hand. If you have a central slip injury, you'll see weak or lost PIP extension, and the DIP will go rigid because the lateral bands have to kick in and they have to attempt to extend that finger. If the central slip is intact and is uninjured, the DIP will remain floppy because the extension force is now placed entirely on maintaining the extension of the PIP joints. The lateral bands are not activated, they're not needed, and the central slip is doing its job. Radiographs or x-rays of an injured finger with this type of injury are not necessary to identify this unless you suspect that there might be a fracture. Conservative management involves treating these acute injuries with splinting the PIP joint for 6 consecutive weeks in PIP extension. You want to allow for DIP flexion and extension while the PIP is held in full extension during those 6 weeks so that the oblique retinacular ligament, which is a ligament that connects the flexors to the extensor mechanism, doesn't get tight itself. There are many splint options that we can use. Here on my left is a little aluminum splint that's taped in place. This works well for a temporary one before the person can maybe get over to have a customized orthosis, such as you see over here, C on the picture on your bottom right-hand side. I have an X over this Kapaner splint. This is an extension assist splint, allows the DIP to flex, but can allow the PIP to flex as well. So this would be an inappropriate splint during those first 6 weeks. This is another version that is available on the internet. It is a splint that will hold the PIP in extension. However, you can see it blocks the DIP from flexing. So this would not be your best option either. The conservative protocol should be established as soon as possible. So again, clinically important to catch these injuries early. You should have a low threshold for treating these by immobilizing them and then referring them out to have a further examination done to confirm your suspicions. In an immediate injury, if the mechanism of injury and the exam is suspicious for a boutonniere injury because you see pain over the dorsal PIP joint, you see some extensor lag or some weakness with extension, and you have a positive Elson's test, then you want to immobilize that PIP in extension using a temporary dorsal or volar splint and refer that patient urgently to a clinic or a physician or a hand therapist to address this issue. Do not buddy take them or leave them unsupported or return them to play. Indications for an urgent referral when somebody is on the playing field and sustains an injury where imaging is needed would occur because of a high injury mechanism that may indicate that there could be a fracture or a dislocation along with your tendon injury, or if there's an open dorsal wound. Now, what happens if this goes unchecked? So person has an injury, they don't think much of it, they continue to play, they come back within the first week and you see them, they're complaining of pain and swelling and starting to have some difficulty extending that PIP joint. If it has not happened already, please refer that athlete over to a specialist who can do further testing and get them set up with an appropriate orthosis and with the appropriate protocol. That's not to say you don't have a role in the rehab during that conservative period of time. We can't see these patients as often as we would like for insurance reasons, for cost reasons, et cetera. So we depend on those who are outside, such as yourselves, to be checking to make sure there isn't skin maceration underneath the orthosis and that they are complying with that treatment protocol of maintaining full extension at that PIP joint and doing regular DIP flexion and extension exercises. Now, what happens at 6 weeks? So we've immobilized them successfully for that 6 weeks period of time. We remove the orthosis and we start a gradual graded program to resume flexion at that PIP joint. We don't stop splinting though. At this point, that tendon is no means as strong as it's going to be. It typically takes that tendon at least 12 weeks. So we're going to start some intermittent motion because we know that that joint is hard to rehab if we keep it straight for a total of 12 weeks. So we'll start doing some removing of the orthosis throughout the day and doing some specific exercises and watching how that patient responds to that. We'll use nighttime. It's the best time possible to continue using that orthosis and keeping that PIP joint in extension for another 4 to 6 weeks to get us up to our 12 weeks of protection. I would much rather a stiff PIP joint inflection with an intact tendon than an attenuated tendon, one that's overstretched, or one that's stretched out too fast, resulting in a resumption of that boutonniere deformity, because it's just that much less likely that we're going to get a good result without surgery. So again, prognosis is really good if it's treated early on and treated appropriately. Delayed diagnosis by several weeks makes non-operative success less predictable and may require surgical intervention. So in conclusion, zones 1, 2, and 3 are the most common injury sites in sports for extensor tendon injuries, such as the mallet or boutonniere injury, or even the swan neck injury. Early recognition prevents deformity and long-term extensor lag. Your clinical judgment is crucial to these overall outcome for your athlete. Splinting position matters. For zones 1 and 2, the DIP joint needs to be in full extension for a minimum of 6 weeks. For zone 3, the PIP joint needs to be in full extension, the DIP joint needs to be free, and the patient needs to be regularly exercising that DIP joint. We do suggest that when in doubt, refer them out. Open lacerations over the extensor tendon need to be referred out, and inability to actively extend any joint should be assessed by a hand surgeon or hand therapist, and the possibility of a fracture or a joint dislocation in addition to a tendon injury should be referred out. So we thank you for your attention on these 3, and we open it up to any questions.
Give the attendees a couple of minutes here to get questions in. And similar to now, we had about 70 attendees, just as an FYI for our speakers.
Great.
And definitely a lot of good information for the athletic trainers. I know they certainly are the first people to be putting eyes on
These
all
injuries.
of these different injuries. Yes.
Yes, exactly. And we appreciate your patience for everyone in the audience as we work through a little technical difficulties. So thank you. If you do have a question that arises after the end of this seminar, and you'd like to get in contact with us, I believe we have our email listed on that first slide. So feel free to reach out by there, and we're happy to provide any further information that we can. We do have an extensive reference list for you as well.
We will make sure that the lecture gets sent also so that you have it for review.
Well, wonderful. Well, I will take that to mean that it was so comprehensive. No one has any questions. They're ready to come to Gannon University, join you and become hand therapists.
Great. We would love that.
Thank you very much for your time and attention.
We appreciate you asking us.
Absolutely. No, this is, I will tell you, this has been a topic that for several years we have had requests about going through and going through the hand therapy, and you guys definitely did it in a very comprehensive way. So thank you very much for your time. Thank you for putting together the presentation and working with me in terms of getting the technology. We got it all figured out.
Perfect.
Absolutely.
Thank you, Michelle. We appreciate your help with this.
Of course, absolutely. And I hope you guys have a great day, and thank you to everybody for attending.
Thank you.
Bye-bye.